Okay, so this is artwork by Vesalius. Some of you may have heard of him. He was around, so his birth year dates were 1514 to 1568. So he died at the age of 54. But scary. Apparently the average lifespan in 1890 was 52. So anyone over 52 has to count her lucky stars, I guess. And look at this drawing of Vesalius. Now, he was known as the father of anatomy. He was the professor at Padua University in Italy, and his anatomy was quite superb. Now, in those days, the anatomy departments were right next to the prisons, so that when somebody was executed for stealing a loaf of bread, they could get the cadaver nice and fresh and juicy without any of that formaldehyde in it. And then they got these really nice dissections. And look how he understands movement. Look how he's kind of showing that if you want to throw with your right hand, you need to plant a flex to generate kinetic energy from the ground. That energy then comes up the perineal tendon, and at the superior tib fib joint via fascia links onto the biceps femoris. At the ischial tuberosity, that links to the sacrotuberous ligament, which comes up to the sacrum, crosses via the thoracolumbar fascia to the opposite latissimus dorsi via the glute max. And the latissimus dorsi gives off a sleeve to the inferior angle of the scapula, so that when you throw, you've got this whole kinetic energy force being generated. And it's quite fascinating that this was coming out in the 1500s, whereas now we seem to have lost the plot. Now everything we look at is a subgroup. You know, we've got a shoulder specialist, we've got a hip specialist, and often the two just don't chat. You know, if you've got a back problem and you go to the GP, you probably tell you you've got a kidney infection. If you go to the psychologist to tell you that, you know, things are really not great at home. If you go to the gynae, he says you've got endometriosis. If you go to the gastroenterologist, he tells you you've got a spastic colon, and so on and so forth, because no one's really chatting or making detailed assessments. Whereas Vesalius really had a much better understanding. And this isn't how the starving people were executed. This is how he dissected. And so what he did is he dissected in weight bearing. So he would string the cadaver up in a weight bearing position, and by keeping the fascia intact, you could actually see the proper relationship between the different muscles and understand that they all worked together and not as a team and not as individual units. So that's actually how he dissected, and that's really quite fascinating. I find it very fascinating. Now, what happened to Vesalius? So everyone used to follow him around, and if somebody died, they'd all march off to somebody's house and dissect him. And some very wealthy person died at the top of a hill, and he traipsed up the hill surrounded by a whole lot of anatomy students, and got to the cadaver, or the person who just recently passed away, cracked open the chest, and unfortunately for Vesalius, the heart was still beating. So he got into a large amount of trouble, and there was the time of the Spanish Inquisition, and they spared his life and put him on a ship to Jerusalem as a pilgrimage to redeem himself. He gladly got on the ship to get away from all the trouble he'd caused, and unfortunately on the return journey, the ship hit a rock and sank, and he is buried somewhere in the island of Zante on the Greek Isles. So that is Vesalius, but it does really does fascinate me how we're 500 years down and we seem to have gone maybe a little bit backwards in some way. So why do we need an integrated approach? Because often it's a multifactorial pathology, really. You know, it's just no such thing as a simple problem. And the more you know, once you start to question what the sources could be, flip the job gets much more exciting. It really does. You know, I spend a lot of time like assess, reassess, see if I can find the source. And that's the bit that really stimulates me and makes me a happy person. So we want to improve outcomes, decrease recurrence rates, all being validated. And somebody's obviously coming through with chronic pain and central mediated components and fear avoidance and so on, is that we want to promote patient education and self-management strategies. So we need to get the patient to buy in And so the more we can explain to the patient what we're up to, and educate them about fear avoidance, catastrophization, coping strategies, how we need them to partner us in this management strategy, the better outcomes we'll have. And obviously we want to improve sports performance. So multifactorial pathology requires a multifactorial approach. And why are we not all walking around with the perfect posture? Because we're never in a symmetrical position. A lot of the stuff that we do is not symmetrical. So things like sport-specific training. So if you continuously train serving, volleying as a tennis player, of course you're going to get asymmetry. Look at the asymmetry in Nadal if you compare his dominant left arm to his non-dominant arm. And so this repetitive excessive loading will create these asymmetries. So this was a Shirley Salmon comment, and that is that you get what you train. So the more you train asymmetrically, the more dysfunction you'll have. And that's why, for example, if you're a track athlete, you shouldn't just train running anti-clockwise around the track. You should actually be training going in the opposite direction as well, which they absolutely hate to do, but to try and get a bit more symmetrical. Inactive people, so it's not just sporty people that get these postural dysfunctions. Inactive people sitting in slump positions or persistently sitting, constantly leaning or rotating in one direction, standing with the baby on one hip, and all of these overload certain areas. And Shirley Salmon, again, always had these fantastic one-liners and says that osteoarthritis is a normal response to an abnormal load. So yes, of course, you get a genetic component to talk about, and you get a systemic seronegative spondyloarthropathy type component, but a lot of osteoarthritis is just normal. It's normal response to an abnormal load. We can't change the osteoarthritis that you have, but we can reduce the loading to stop you getting more. So osteoarthritis is a normal response to an abnormal load. We need to identify the source of that and correct that and reduce the loading. Modifying factors, age, obviously the older we get, the more we load. Females, highly intelligent. Unfortunately, the price we pay for that is very wide childbearing hips, which increase our femoral adduction internal rotation. Super tall people have more problems than much shorter people because of gravity. Obesity is obviously highly linked to overload. Genetics, you can't pick your parents, unfortunately, and you can inherit certain conditions that will predispose you to overload and postural dysfunction. Hypermobility, of course, we'll talk about, and that's a biggie for me. Some people are genetically have got heavy arms, large breasts, and those type of things increase your loading and would push you into a kyphosis, which would give you a loading component. You could have a predisposition, of course, to OA, or an underlying Sherman's disease or an autoimmune disease, for example. Other modifying factors, comorbidities, diabetes is obviously a big one, renal disease, steroid therapy, activity level, doing too much, lockdown, doing too little, lockdown. We had our first book club get together on Saturday, and there's 11 of us, and I must say I thought that the net mass of the group had probably gone up by 10 to 20 kilos. So because of lockdown. So, doing too much and too little. So tendons just don't like changes in load. They like to be titrated constantly up. So, either going mad or doing nothing, or neither are helpful. And psychosocial factors influence us. We know that smoking, for example, has a propensity to slow healing and increase inflammatory responses, as does poor sleeping habits. So sleep hygiene is massive. If you've got flu, you need to sleep. But if you've got deep gluteal pain syndrome, you need to sleep because sleep is recovering. And obviously we need to look at all their lifestyle, work environment, job satisfaction, social environment, and so on. And all of those are actually modifying and influencing factors onto biomechanics and postural dysfunction. So Punjabi in 1992 said that if we want to get control of the neutral zone, it's not just about getting one activity such as force closure. We need to get all three subsystems to work together. So we need the passive system, which is form closure, the active system, which is force closure, and the right muscle to fire, which is the neural control and the motor control. And obviously we've extrapolated that in the last 30 plus years. Working on my maths, but it's close enough. And effectively, all the subsystems must work as a team sufficiently to transfer load safely and effectively. So we want optimal function in our patients. So we've talked about the neutral zone. And so we need, first of all, we need to respect and be cognizant of the biopsychosocial components. Is the patient fearful? Are they anxious? Are they depressed, catastrophizing, and so on? And then we need good form closure, which is end range stability, and that's the integrity of the bone and the ligament. Then we need good force closure, which is mid-range dynamic stability, which we'll talk about. In motor control, we need the right muscle to fire at the right time for the right task. And Diane Lee would often liken this to effectively, if you are listening to beautiful music at an orchestra where the violins come in and then the cellos come in and then everyone else comes in sequence, that would be an example of motor control. And if you're listening to this sort of like wild rock, maybe jazz or something where everything comes in at different places, that might be example of this mess. I prefer the mess, but it gives you an example of perhaps we're not getting that optimal motor control because you want the right muscle to fire at the right time for the right task.